Good morning, good afternoon, good evening from wherever you're joining us from. My name is Dr. Jemima Karaoke. I am so happy to be here today. We are going to be discussing about polycystic ovarian syndrome. As you're all aware that this is the polycystic ovarian syndrome month. It was actually on 1st of September, but I've chosen to have this webinar today because really polycystic ovarian syndrome is something that affects so many women. We have about 1 in 10 women who are affected by this particular syndrome. And it is one that can cause a lot of self-esteem issues. Even as we talk about mental health, it is one that can cause issues of depression, issues of low self-esteem, infertility. So really understanding what PCOS is all about is really key to improving our health as women. And most of the things that we actually struggle with, or you may find that you're struggling with, may be actually related to this particular syndrome. For example, if you've been having issues with your hormonal balance, that means your periods are not regular. They used to be 28 days, but as you're progressing, they're going to 30 days, they're going to 35 days, 40 days, sometimes even 2, 3, 4 months without having your normal periods. Then, of course, we know that is not normal. In the teenage years, we say that for the first 2 years, there's a bit of instability when it comes to the hormonal pattern of the female. But beyond the first 2 years, and especially after 16, actually after 18 years, then we want to find out why are the hormones behaving or misbehaving, and why are your periods not coming every single month. So a normal period is supposed to be 28 days plus or minus 7. So that means 21-day cycle is okay, a 35-day cycle is okay, but it has to have been 35 days all through, okay? But anything that's going to 38, 42, 45, 60 is, of course, abnormal. Okay, so that's one thing that you could be suffering and you don't know that it's a problem. The other thing could be that you've stayed for more than 12 months trying to look for a baby and you can't find out what's wrong. Everything in the scan seems normal. You're just told it's a hormonal imbalance, or you're having weight gain that is unexplained. You've checked your husband's semen, you've checked your own HSG, which is what we check, what we use to check the tubes, and they're normal, and yet it's becoming difficult to conceive. So one of the things that we may want to check as gynecologists is whether you have PCOS or polycystic ovarian syndrome. Okay. The other thing that is so common and we don't think that it's common is actually hair. That you have male pattern hair, that you have a beard that is starting and then it goes sideburns, it's coming all the way. You have abdominal hair, you have chest hair, back hair for some women. And it's something that was not there before and now is increasing, especially as you grow older. So we call that hirsutism, which is male distribution type of hair. Okay, so this is something that we would want to kind of expound on today, and I really want to see all of us get involved. If you have questions, please answer. I want to really thank Mayors for giving us part of this presentation, Harley's for giving us part of this presentation as we start. So PCOS, as I've said, is a condition in which there's hormonal imbalance. In fact, most of the time you'll not be told you have PCOS. What you'll be told is that you have a hormonal imbalance, and it can be written off as something that is not exactly a big problem. But as we go on, you will see that it's good to advocate for your rights as a patient, that if you've been told hormonal imbalance, what type of hormonal imbalance is it, and is it likely to correct or not? Okay, so as I've mentioned, it will have irregular periods, you may have increased hair, you may have acne, you may have infertility, and weight gain. I'll pause here and talk about weight gain. We have gone to such lengths to body shame people, not knowing the kind of issues that they have. Because as we go into the pathophysiology, you'll understand that sometimes the weight is distributed only around the abdomen. And if you're one of those lacking ones, can go to your thighs, it can go to your behind, but it is still not the right kind of weight. It's not muscle, it's just fat. And it's because of insulin resistance, which as you've seen down there, we have insulin resistance. So please, you may not know what someone is going through. So if you've seen someone with weight gain and they're having fertility and they have so many issues like their periods are normal, etc. Instead of body shaming, you can guide them. Why don't you see your gyna, or just send them the video and don't share so much, because you don't know what someone is going through, and body shaming is really not the way, not the way to go about it. Yeah. So, what are the common symptoms of polycystic ovarian syndrome? One is irregular periods. I've mentioned this, or no periods at all, sometimes up to 6-8 months without a flow. If you are on the progesterone implant, this does not apply to you. If you're on any progesterone-based contraceptive, this does not apply to you, because what you have is lack of periods due to the progesterone effect, right? But if you're not on any contraceptive and you're not having your regular periods, then that is a problem. An increase in facial or body hair, usually we'll notice the face, then it will go to the body. Loss of hair on your head, which we describe as alopecia or male type baldness. Okay, it's caused by increase in testosterone. Overweight, or experiencing a rapid increase in weight, or having difficulty losing weight. Okay. And then acne prone skin, and it's because of androgens, especially testosterone and dihydrotestosterone, causing increased sebum across the face or across the facial sebum glands. So with increase in sebum, then you have increase in acne, and then because of the increase in acne, you're likely to have them get infected, and then it becomes a loop. Okay. Infertility, I've mentioned. Depression and psychological problems can also result from this. And this I've gotten out of the Green Top Guidelines, which is the Royal College of Obstetrician and Gynecologist resource for guiding on PCOS. So what are our highest concerns, or what really is the problem with PCOS? There are two driving factors: the hyperandrogens and the hyperinsulin, or the insulin resistance. And I'll let you know in a minute how that works. So this is the normal physiology, okay? In the normal female body, we have the brain connecting to the ovary, connected to something we call the pituitary gland, still in the brain, and connecting to the ovary and then the rest of the body. So that's one of the axes that we have. In the men, we have a hypothalamus pituitary testicular axis. But for ours as females, we have a hypothalamus, which is in the brain, pituitary still in the brain, and then ovarian axis. So what happens is that every month, I hope you can see this, we have the hypothalamus secreting GnRH, which is gonadotropin releasing hormone. And it has a pulsatile manner. It's in a regular rhythm, okay? And then that regular rhythm releases two hormones. It has the luteinizing hormone, or LH, and then it has the follicular stimulating hormones. Both are very important, and both are very key for one to produce the eggs, rather mature the follicles into eggs, and then cause ovulation. Okay, so these two hormones then now go to the ovary. The ovary is right next to the uterus. So when they go to the ovary, they trigger the follicles along the ovarian along the ovary to release estrogen, and then this estrogen causes the follicles to grow, and then the follicles grow, and then there's something we call an luteinizing hormone surge. And then when there's that luteinizing hormone surge here, you can see here, then the egg that has grown is now released, and then it goes and implants in the uterus because the uterus has been preparing for the egg. So that is normal. Brain releases FSH, LH, LH goes to the ovary. They trigger the follicles that were there from birth to start developing. And then the follicles keep growing until one of them matures. And when that one of them matures, it now bursts and what we call ovulation and goes into the fallopian tube, fertilized, and then is implanted into the uterus. So that is normal. However, I hope this will make sense. However, in the polycystic ovarian syndrome, that pulsatile index that we had mentioned is lost. So what happens? GnRH now is released in a very fast manner, very, very rapid or fast manner. So between the hormones LH, between the hormones luteinizing hormones and follicular stimulating hormone, LH responds better than FSH to a rapid or a fast impulse by the hypothalamus. Okay. So what happens then? This LH goes and goes into the ovary, around the edges of the ovary, and the FSH will still respond, but not as much. So it will start allowing some follicles to develop, but because it is not so much, the follicles will not develop until the desired size for them to ovulate. So the LH now does not have something triggering it to grow, to have a surge and then ovulate. So what happens? Because it can sense there's a lot of follicles, it will now start aromatizing, or in simpler words, changing the estrogen that is there to androgens. Okay? And then those androgens now also inhibit ovulation from happening. So that's this testosterone that you see here. Okay, and then when that testosterone is built up, it goes to the pancreas. Okay, and then that testosterone causes insulin resistance. Okay, that insulin resistance causes more GnRH to be called, and then that more GnRH called brings about more faster pulsatility, and then more LH is surged, and then it comes down. So it's a loop. Literally, it's just a loop. Okay. So as you continue, follicular stimulating hormones becomes less, and luteinizing hormones becomes more. So follicular stimulating hormone, remember, is supposed to take small eggs that are there, follicles that are there in your body, or eggs that are there in your body, and make them grow and mature so that they can be ovulated. So because now these follicles are growing but not enough, they now go to the side. Then they become so many because there are many cycles that are not producing eggs that are being ovulated. So they come, and you can count there are so many eggs, which is not normal. Normally, you'd have 5 or 6 in any count. So here we have so many eggs. So when we count on ultrasound, we'll see more than 9 eggs, okay, or follicles. And those follicles are what are called cysts. So polycystic is actually those cells that did not ovulate, those eggs that did not manage to ovulate, that are now at the corner of the of the ovary, that now become the polycystic ovarian syndrome. Okay. The other thing is that because there's so many small follicles, we call them antral follicles, then this hormone, anti-Müllerian hormone, which essentially is released by those follicles and tells us how many eggs do you have, that hormone rises. And the more it rises, it goes to trigger the gonadotropin releasing hormone, and then the cycle continues. Okay, so I hope we are still together. So that is the pathophysiology. So the diagnosis is from the pathophysiology. So if you have a lot of this can, you will have a larger ovary because it's being pushed by the cyst, and it will look like it has many tiny cysts. So on scan, we will see polycystic ovary. It can be on one or it can be on both. Okay. Then because they're releasing small levels of estrogen that are being converted to testosterone, then you will have higher androgens. And please, men and women both release androgens. So it's not a male thing, but women reproduce them at a smaller or a lower rate, okay? So that testosterone is what will give you the androgenic effects. For example, it will give you weight gain. For example, it will give you balding. It will give you hair that looks like that of a man, okay? And then it will give you insulin resistance, which we mentioned. So we never know what started first, whether it was the insulin resistance that brought the testosterone or whether it was the testosterone that brought the insulin resistance. But both are present in polycystic ovarian syndrome. Then we've talked about not ovulating. So if you're not ovulating, therefore it becomes difficult for you to conceive. That's how the infertility comes in. And if you're not ovulating, then your periods can then the periods change or alter. So you don't have the normal 28, 21, or whatever cycle, because there's no progesterone that is affecting or controlling that effect. And I forgot to mention, progesterone has a very important role in regulating the gonadotropin releasing hormone. In fact, it is what is missing that would make gonadotropin releasing hormone come back to a normal pulsatility index. And with that pulsatility index, you get back your normal FSH, your normal LH. Okay. So, I'll go now to the diagnosis. I've mentioned about oligo or anovulation, which just means your periods are not regular. It's when they come, they are minimal, and you stay many days without seeing them, or no periods at all. Then you have biochemical changes, which could be high testosterone, high androstenedione, or DHEAS. All of them are androgens, or you would have clinical symptoms, that is acne, hirsutism, acanthosis nigrans, which is a line that comes on your face and sometimes on your chest. So those three, it's either or. It's either you have the biochemical, we've tested in a lab and seen, or we look at you and we can see you have hirsutism, you have acne, and then we look at a scan and we see that it has greater than 12 follicles, those two cysts I was showing you, or the ovary is increased in volume, which is greater than 10 cc. So any two, if you're an adult, we can diagnose you as PCOS. If it's a teenager, it has to be all three. Okay, so that's just one of the differences. Now, what are the long-term health effects? This, I think, is where we need to spend most of our time. So, for example, if you have insulin resistance based from the pathophysiology, then this insulin resistance causes a lot of harm to your body, and the main one is actually diabetes. Okay, it's actually diabetes. So if you have PCOS, you have a likelihood later on in life, especially above your 40s, to get diabetes. Okay, it's also possible for you to get, if you're pregnant, gestational diabetes. Okay, which is diabetes that presents itself in pregnancy. That's number one. The other thing is that it is associated with high blood pressure. Okay, this is part of what we call a metabolic syndrome, where you have insulin resistance, which increases your cholesterol levels, the bad cholesterol. The bad cholesterol goes to the artery. The artery blocks the artery. It causes thinning of the pipe, and then that pipe now gives you high blood pressure. High blood pressure causes more bad cholesterol. So it's also a loop. So that high blood pressure is what would now give you heart disease, because it's forcing your heart to work harder than it ought to. Okay. Then we have so even cholesterol here, if we measure your cholesterol, for some people, especially in advanced PCOS, we may find that you have high cholesterol, high bad cholesterol. Let me use that. Okay. Then we have endometrial cancer. Endometrial cancer would come from prolonged periods without having a period. Okay. So if you're not getting your normal menses for greater than 3 months, it is important for your periods to be triggered. And how that would happen is either through a progesterone hormone or through contraceptives like the COCPs, or the trying to get the combined estrogen contraceptive pill, okay, Femiplan and those ones, or you can have a hormonal based implant called the Mirena. Why am I saying so? Even if you're not getting your periods, remember your cells, or the cells of the endometrium, every month are preparing to carry a baby. So if these cells are preparing to carry a baby, they're going to keep growing. And as they keep growing, remember, they are fed by estrogen, and your body has high levels of estrogen, although E2, and high levels of androgens. So they'll keep growing. So as they keep growing, they can now mutate or change to become hyperplastic or cancerous. So that's why it's important, if you're not getting your menses, to please have them triggered. Again, this is not this does not apply to anyone on a progesterone based method of contraceptive. Okay, so if you're on a progesterone based method of contraceptive, you may find you don't get periods, but because it's progesterone as the underlying hormone in the contraceptive, it is safe. It protects you from endometrial cancer. I'll stop here to say PCOS will not give you ovarian cancer. It's protective. Okay. Or tube cancer, which is fallopian tube cancer, or breast cancer. But endometrial cancer or uterine cancer is possible. Infertility, and we've mentioned how. And it can also, it doesn't mean that you don't ovulate all through. There are some months where you will ovulate when the hormones surge high enough, and you may actually conceive. And many women with PCOS actually conceive with small changes in their lifestyles, and we'll get to that. And then we talk about depression and mood swings as a factor of self-esteem, as a factor of the hormones being dampened and high stress levels because of cortisol. Then you may end up with having very high, having depression and mood swings. Snoring and daytime fatigue, I picked it. I picked it from, again, the ARCO guidelines, but I'm not so sure how it works. And I'll be honest, I'm not so sure how that particular works, but I thought it important to mention it as well. So can PCOS be treated? We actually say that it is not curable, okay? Because as I've said, it is an interplay of your hormones. It's a hormonal imbalance disease or syndrome. And once the ovary changes, then it becomes a type of ovary, okay? But the symptoms of PCOS can be managed, okay? And I don't negate the factor or prayer or miraculous healing. I don't negate that, so please don't take me to court. But what we say medically is that there is no cure for PCOS. We actually just manage it. And you can adequately manage it with your own lifestyle so well that we don't need to give you any medication. And how do we know that you manage it well? When your periods come back to normal, when your acne has reduced, you may have weight loss, you may end up with reduced hirsutism as well, and of course, fertility, because one of the main issues why we end up treating PCOS is because of infertility. Okay. So, what are these healthy things that you can do for yourself? If you have any of the symptoms that I've mentioned and you're already scared, please don't. There are things that you can do right at home before you even come to see a gynecologist, although it's important to see a gyna. So number one is to eat a healthy, balanced diet. I mean, a healthy, balanced diet. And this diet should be devoid of high oils, processed food. Just your good raw vegetables are good. Your fruits are very good. Wholemeal bread if you can. Tuberous starches, tuberous starches like the cassavas and the potatoes and such. Then of course cut down the amount of sugar, salt, and caffeine, because as we've mentioned, there's diabetes, there's hypertension, there's lipidemia in the background. Eat your meals regularly. Even if you're trying to do a fast, we really insist that you have a heavy breakfast, and I'll mention why as we proceed. Then exercise regularly. 30 minutes of high intensive, okay, we actually say moderately intensive exercise. Okay, so that means either running, walking, swimming. Those are very good moderate based exercises. Okay, and of course we really encourage weight loss. But this is not to say that if you're thin, you don't have PCOS. Are those we call lean thin PCOS. If you're in that category, then weight loss may not really do you good, because I mean you may be very lean, okay, but it would be good not to do the other things, the healthy diet and the exercise and what have you, but just for a good well-being, not so much as to change the symptoms of PCOS. Okay. So please, if you're 50 kilos or 60 kilos and you're within your BMI, don't try to go underweight. This is what I'm trying to say. We're not advocating for malnutrition as a treatment for PCOS. Okay. So vitamins, the micronutrients that can actually help you with your PCOS journey. And some of these things you can get them from the sun, like vitamin D3. Vitamin D3. Although the studies that have been shown have shown if you supplement these things, you're actually going to improve your outcomes, especially if you're dealing with fertility or anovulation, which means your periods are not regular. So they recommend 1,000 international units of vitamin D3. Myo-inositol is one that has been shown to really improve health. And it's important that you be able to get this. Okay, these are enzymes that are seen to improve the egg quality by improving how the egg responds to the hormones. Okay, magnesium actually helps you with sleep. PCOS aside, magnesium helps you with sleep and helps you with muscles. If you get a lot of muscle spasms, it helps you with that. But 300 milligrams of magnesium was actually found to be very effective in helping with PCOS. I've talked about vitamin D3 again, I'm sorry. And then we have vitamin B12. It improves your health. It improves folate deficiency if you have megaloblastic anemia. And it also has been seen to improve PCOS. These are vitamins. They are vitamins. If you can get them in food, if you can get them in supplements, if you can get them in they are good for you. They're good for you. We have beta carotene, we have antioxidants, and some of the and L-arginine. Some of the antioxidants are actually found in natural food. Okay, but if you and vegetables like the stinging nettle is a very good antioxidant. But in case you're not able to get all of these things, then you're possible for you to get supplements that are over the counter, something like Overcare Mayo. It's something that's really been well designed to help with PCOS, and you can get it over the counter. There's another one that I didn't mention is omega-3. Omega-3 is really key. Even from American Heart Association, which is the association that talks about health, the heart and heart health. They talk about eating fish thrice a week, eating fish that is highly oily, so for lack of a better word, or has high levels of omega-3 thrice a week. So that's sardines, that's salmon if you can get them, or you can just get omega-3 supplements. Okay, they talk about 3 milligrams for PCOS, but I think if you can supplement yourself for 12 weeks, good to go. If that's not possible and you're able to get the fish itself, good for you. Healthy, natural is always better, but these are just things that can improve your health. Okay, now if you think you have PCOS, please talk to your doctor, talk to your gynecologist, book a visit, because early diagnosis can improve your well-being. Okay, and that includes whether you're seeking to have a baby. If you're not seeking to have a baby now, you still can get pregnant, especially if you start exercising and all those things. So please, if that's not your pathway, then contraceptive would be very key for you. And if you need to talk to us as Wills for Life, please, you can reach us at that number, 0719 11 66 11, or you can find us on our app. Our app is on Google Play Store. You can find me there. Consultation is $7.50 right now. So please don't feel alone. We have virtual consultations for you across the country, across the world. And you can always use this as a resource, as a starting point, that when you're going to see your gynecologist, at least you're starting from somewhere. So with that, I'm going to go back and remove that. Yes. And so that now we have time for questions. Okay, dokie. I can see there's so many questions. Thank you, Bridget, Fazira. Okay, let me start from here. Okay, so do I have to have my vitamin D3 checked before I do those supplements, or can I just get them over the counter and take them? Usually, it would be good to do your vitamin D3 and calcium levels, actually, especially if you get a lot of general fatigue. If you get a lot of general fatigue, you're always tired and you can't pick why, and your HB is normal, then it should be good to check your vitamin D3 and calcium levels. However, you can always buy and take over the counter, okay? Because more will not affect you. Your body will just remove what is excess as toxins, and you should be fine. Okay. I hope that answers your Fazira. Now, if you mention if one doesn't get her period after 3 months, you should be concerned. Does this apply to breastfeeding women, since I know one can go for months without their periods? No, this does not concern breastfeeding women. One, when you're breastfeeding, you have high levels of prolactin, you have high levels of progesterone, and prolactin blocks that GnRH I was showing you earlier. It actually blocks it so that the hypothalamus releases less FSH and less NH. So that when you find that especially if you're breastfeeding on demand, you're at home and babies are in your boob every other minute, you may find it will take very long for you to to start getting your menses. However, if you go beyond 2 years and you're still not getting your menses, I would recommend for you to be seen by your gynecologist. Okay, after 2 years, ideally, you should have a resumption of your periods. Oh, I actually have answered. It's not working, but the question here is asking also how long is too long for a breastfeeding mother to go without their periods, and when should you be concerned? Some people can go for 2 years as long as they're breastfeeding. Yeah, 2 years. 2 years is where we know everything is okay, we are within normal. After that, we want to find out, is there a problem with your thyroid, is there a problem with your prolactin? And by the way, I've mentioned all these things to do with your hormones as PCOS, but sometimes the problem of lack of periods may not be so much PCOS. It could be that you're having a thyroid issue. It could also be that you're having a prolactin issue, okay, where they're too high, or a growth in your brain that now prevents you from getting the normal hormonal surges. As you've seen, everything in the female reproductive system, or in any other system for that matter, starts from the brain. Yeah. So if you find that you're getting an issue, let you be tested for your thyroid, let you be tested for your prolactin, even as we're looking for all the things to do with PCOS, so that we don't have you misdiagnosed. The other thing is that if you have PCOS, then you need to do particular health checks. Okay. For example, every 1 to 3 years, you need to screen for diabetes. Okay. You need to, every time you go to your hospital visit, you need to screen for at least your blood pressure. That is an easy thing because it tends to be triaged often. Okay. You need to look at your lipid profile. So you go having without any meal and you have fasting lipid profile done. Okay, that checks for you whether you're having bad cholesterol or good cholesterol and how your heart health is. Okay, so if at all you go now to diabetes, you will find that as you start exercising, as you start taking these good foods, as you start watching what you're eating, then slowly you will revert back. Okay. It's actually said that if you're taking your meals, and I had forgotten to mention, if you're taking your meals, especially early in the morning, you have your breakfast, they're talking about 960 kilocalories. I don't know who counts their calories, but if you count your calories, we're talking about breakfast at 960 kilocalories and lunch at 360 and supper at 100 or something like that. But basically, have your breakfast as your heaviest meal, have your lunch as a slightly heavy meal, and then dinner as a very light meal. And then you will find that the sugars will control, your weight will go down, and even the PCOS symptoms can actually go back to normal. Okay, where now you're having your regular periods even without external help. Okay, and there are other treatment modalities that I didn't speak about. For example, we have insulin sensitizers because we have insulin resistance in PCOS. So if I give you an insulin sensitizer, it helps your body respond better to the insulin, and then that helps drive out the excess fat to be excreted out of the body, and then you end up with weight loss, and then that also helps with the hormonal balance, and that can improve your health dramatically. So one of the insulin sensitizers you'll be told about would be something like metformin, but of course your doctor will guide you better. Okay. Yeah, so I hope that answers that question. Now, is it normal to have a heavy flow for last 7 to 8 days, such that I can't wear normal pads but resorted to diapers? I also have high blood pressure and mood swings during my periods. That's not normal. It's not normal for you to have, first of all, that flow is very heavy. If you have to use a diaper, we may need to do a scan and find out why are you having such a heavy flow. Do you have adenomyosis? Could it be fibroids? Could it be just hyperplasia of the something is off, and that's why that flow is that heavy. Okay. As for the high blood pressure, it's important to check whether there are other factors, like are your periods normal in terms of duration? Do they come every month? And is there any other factors such as, for example, hyperthyroidism? Because one of those two things you've mentioned, the high blood pressure and the heavy flow, are things we see in hyperthyroidism. So it may be good for you to go in and get a check. And of course, even mood swings, that there's such a condition as PMS, which we call premenstrual syndrome, that can come with altered moods. And that's because of the drop of estrogen in your body as it's starting to rise back. Okay, so no, it's not normal. Please have a check with your gyna, and they may guide you better on what is, and they would do some tests to check what is the issue in this regard. Okay, I don't know if there's any other question I haven't gotten. Good. I think we've covered it really well. I'm really happy. Please, if you have any questions, please do check on it, or ask in the comments is what I'm trying to say. Ask in the comments. If you haven't liked, please subscribe to the channel. It will allow us to grow more as a community. If you want to join us and be part of our community, our number was in the slides of 0719 11 66 11. That is where you can find us, and we'll add you into our community of moms, especially if you have a baby under 2 or you're looking towards getting pregnant soon, and we will work with you. We are also on Instagram as Wills for Life. We are on TikTok as Wills for Life. We have this channel as Wills for Life, and we really just love working with you. Once more, my name is Dr. Jemima Karaoke. I am a gynecologist from the University of Nairobi. I am really glad to be with you. Our clinic is in Nakuru, Wills for Life Healthcare. We have our app, Wills for Life, on Google Play. Very soon shall be on iOS as well. And you can always connect with us, connect with our doctors. We pride in being a telehealth center. So work with us, and we love you so much. And may God bless you and be with you. Thank you once more. And Bridget, Shawe, and Fazira, thank you for actively participating. Best class in this class. Yeah, karibuni sana, and God bless you.